So the question was, is there a difference in the approach in therapy between therapists who belong to these schools? Or let me not call them schools, let me call them approaches, orientations. And the answer is yes. Those with the classical vision usually focus more on reality acceptance. Accepting the fact that it is so. Accepting the limitations of life. And you can also make it out from the way they are. They themselves appear so self-controlled and so gloomy. And many of them actually appear very frustrated. The cheerfulness is missing from the room. If you want to internalize a good, reliable, stable object which is cheerful, that becomes difficult. And you see a therapist who is more fault-finding or is seen as such. So you see the person as a very fault-finding, as a very castrating person. It's almost like having a negative mother or a negative father. Sorry, a critical mother or a critical father. And when you go to people who are more positive and with a romantic vision, you see more use of imagination, of optimism, of risk-taking, of going out, of being cheerful, of humor, of not always following the rules and being that omnipotent branch cleaned. Occasionally bringing in the warmth and the cheerfulness of oneself. And as a rule, it is easier to be with people on the romantic side, romantic vision side, than to be with people with the classical orientation. In my own training analysis, I had somebody from the classical orientation and it was very difficult. So my own experience was not so positive about people with a classical orientation. And ideologically, they come out as people on the extreme left in terms of the philosophical, political spectrum. So you can see even in the writings, when you read the books, you can get the feeling that when you read Freud, Klein or beyond, you almost get the more Freud and Klein, you almost get that feeling of a hospital, something you can smell that, what do they call that? Disinfectant. You get the smell of the phenyl. Right? Whereas the moment you get into Jung, Winnicott and Code, you visualize that the happiness of the sunshine. And that is very evident the way people are, their nature is, and therefore what they write. And you should read Swami Ajaya, how he combines Indian spirituality and psychoanalysis. Someday, if you find time, we'll go into it. He has written a very good book called Psychoanalysis, Psychotherapy East and West, a Unifying Paradigm. Someday, if we find time, we'll go into it. Now, what about the efficacy of it? Where is psychoanalysis used? And how do they classify the sicknesses? So the language here is neurosis and psychosis. So in psychoanalysis, the very ancient usage is of these two words, not so much in vogue now, but good to know that once upon a time, we used to have these two terms, neurosis and psychosis. Neurosis refers to that category of problems where there is no break with reality. What we say reality testing is intact, meaning There is no confusion between reality and fantasy. So sicknesses like depression, anxiety, obsessive compulsive disorder, right? All of these sicknesses are neurotic sicknesses. So the person has a problem, but the person is not confused between reality and fantasy. He is very clear what is reality and what is fantasy. So he does not see something which is not there. He does not hear something which is not there. He can think clearly. He is not perplexed in thinking completely. In psychosis, the reality testing is broken. There is a confusion between reality and fantasy. You can have hallucinations and see what is actually not there. You can have delusions, right? Which means some ideas which have nothing to do with reality. For example, you can have a delusion that somebody who is reading news on the news channel is actually talking about you. Or when you are passing through the market, everyone is just looking at you. Or you see something which is not there, or you hear voices which are not there. Or you just can't think clearly. Your thinking process just won't go straight. And we are not talking about the normal impairment that you see in anxiety or deep emotional states. That's not the type of impairment we are talking about. We are talking about a much severe impairment. Yeah, Kiona.
What about, say, psychics who are able to kind of, I mean, this kind of sounds like hallucination, but they're able to picture an event that is going to happen in the near future, and it in reality does happen. So does that also fall under the same?
No, no. That is a separate category which is beyond psychoanalysis to handle. Psychoanalysis will only call it a coincidence, or will call it too much belief in fantasy. So what you are referring to is precognition, that you know what is going to happen in future. Similarly, there is something called retrocognition. For example, you want to know what happened 150 years back when this ship which was sailing in the Pacific drowned, and where can it be found if we want to send the scuba divers today. So there are psychics which do precognition and also retrocognition. Retrocognition is knowing something from the past, and precognition is knowing something from the future. Both these subjects are subjects of parapsychology. So there is a branch of psychology called parapsychology in which you deal with this kind of mystical areas. But psychoanalysis just dismisses this off as though it cannot happen, not studying the evidence which is there in parapsychology. Because evidence in parapsychology is one of the most rigorous evidences today. And my personal belief is that in the next 25 years, we will see parapsychology being engaged with by general areas of psychology, including psychoanalysis. So findings from parapsychology, findings from psychedelic research as to what happens when you take psychedelic substances. Can you access certain areas of your mind not accessible without psychedelics? Yeah.
Earlier,
So this
psychedelics used to be. Sorry, go on.
Freud also worked on cocaine. I heard he also worked on cocaine, and he was also giving his patients this cocaine for consumption.
Yeah, I was about to say the same thing. Psychedelics used for treatment.
So it did not work out the way he wanted, but he felt no, it did not last long because it did not work out the way he wanted, but he himself got addicted in one sense. And finally, when he
and I've heard there are certain places where they give a particular drug to the person, and he goes into some trance, and he comes back. When the person comes back to the original world, he had gone through this पाताल लोक, और पता नहीं क्या क्या उसको दिखता है, ऐसा कुछ है कि उसको अपनी वो एक he comes to know about about themselves. They come to know about themselves. ऐसा कुछ है.
There are two parts to it. Those who take this seriously, they call of this a psychedelic area, which is yet to be fully understood and integrated. And a very big part of psychedelic studies is into shamanism, because shamans have been using these psychedelic substances for quite a long time. So if we go to the Amazonian basin, or you go to other deeper parts of forests where you can meet shamans, as a part of the shamanic rites, psychedelics are often consumed. And one very popular part is ayahuasca, because ayahuasca is not a recreational drug, it is a mind exploratory drug. So it is not consumed so much for entertainment as much for exploration of the mind. And Robert McKenna and a few other people have done very serious studies. Robert McKenna and नाम भूल गया, क्या नाम है, this person is in or was in or is in, I don't remember exactly, California Institute of Integral Studies, a psychiatrist who had out-of-body experiences with this kind of a psychedelic substance, and then spent considerable years researching it. I'll send you the video today after this class of some parapsychological areas. So you can see those people who have researched deeply these areas. For example, Terence McKenna has been to the shamanic rites and been with the shamans and took psychedelic substances as per their ritual and experienced the whole thing. And he comes back and tells us that this can do to psychology what telescope has done to astronomy. That we can see those parts of the mind which are not accessible otherwise. So that is another area which is yet to be integrated into psychology or psychoanalysis, the psychedelic area as well as the parapsychological area as well as the reincarnational studies. So Ian Stevenson has done very good studies in reincarnation and how that affects our constitution in the present life. So it is a question of belief at the moment, but worth taking a look at. So neurosis and psychosis. In neurosis, the reality testing is intact. In psychosis, reality testing is impaired. We cannot differentiate between psychosis and between fantasy and reality. Okay. So all sicknesses at one point of time were categorized into two: neurosis and psychosis. Now, what is the efficacy of psychoanalysis? On what does it depend? Depends on many factors. The type of problem, the sincerity of the patient, skill of the therapist, real life situation of the patient, right? And so on. Many factors are there. But what we see is longitudinal long-term studies tell us that definitely it has a good effect. So scientifically speaking, we are on a firm ground that long-term longitudinal study do tell us that it does give relief. It does give relief, and the relapse is much lower compared to other forms of quick therapy. So compared to therapies which are short, standardized and manualized, and dealing with only the conscious mind, the relapse is much lower. What has come out is, when studies were done to find out which therapy works the best, what has come out is something very interesting, and it says more than the theory, it is the therapist and the relationship between the two is more important. So this is something very important, that somehow some people, by virtue of their personality and the relationships they create, are getting better results than just following a particular school of theory. And here we come to the basic principle of healing, that everything works on someone and nothing works on everyone. That we need a basket full of tools to mix and match for any given situation. And we find all groups of people. Some people will say one strip of tablet, one strip of Prozac did better than 10 years of therapy. And some people will say 10 months of therapy was better than 10 years of Prozac. So there is no one thing that is an absolute truth. Different people are saying different things. Experiences are different. And one of the things why we take so long is people don't come to us in the mild condition. People come to us only when the condition is moderate or severe. So we divide the intensity in three categories: mild, moderate, severe. And in the mild category, people try to heal it themselves. They try to talk to family. They try to talk to friends. In India, they also go to some priests. They go to some temples. Right? And only after nothing of that works, they actually come to us. Right? So we get, unlike in the West, we don't get mild patients. In India, we get only moderate or severe. Very rarely we get anybody in the mild condition. What are the key criteria? First is patient selection. And there is something very important to note. Everyone is not cut out for psychoanalysis. Unfortunately, the race to have patients and make money and satisfy one's ego is so high that no therapist tells the patient that you are not cut out for this therapy, and people take any patient to come see. But the reality is that there are different types of patients. Category 1, those who are so fragile that no therapy can be done. Second category, those who are so fragile that only supportive therapy can be done. And in the first category, there are also some patients who just don't want to let go of some unconscious or conscious pleasures, or don't have any trust in therapy process, or are just not psychologically minded. They just say, give me tablet and get done with it. I don't want this thing. So that is the first category where you cannot do therapy, either because of too much of fragility, too serious a condition. The person may be so depressed that he even cannot come for therapy, or he just does not trust in the process of therapy, or he is just too fragile. Nothing could be done. Even the frame of therapy itself disintegrates. So that is category 1, where we cannot do psychoanalytic psychotherapy. Category 2, we can do only supportive psychoanalytic psychotherapy. We cannot do what is called interpretative therapy, which is the real therapy. So we can only play a supporting role, a positive role, admiring role, right? A holding role, but we cannot do the hard work of showing the mirror or asking for difficult feelings or telling the person difficult things about himself. So that is a second category where we can do only supportive therapy, which is a very diluted and a very customized version, in the sense we proceed on the basis something is better than nothing, and we hope someday the person will move from the supportive category to the interpretative category. Then the third category is where we do real therapy, the interpretative psychoanalytic psychotherapy, the real therapy. And the fourth, highly functioning patients, where we can even go for a stronger version of interpretative therapy, which can also be confrontative at times. So we can not only do difficult interpretations, but also at times confront the patient. Because the patient is so healthy now that you can do confrontation. He is not so fragile that if you do confrontation, it will just break him apart. So we divide into four. Those we cannot deal with, those where only supportive can be done, those where interpretative can be done, and those where even confrontational can be done. And it's very necessary to, after taking the case history and maybe for first 1 or 2 sessions, to be clear what is the type of person we are dealing with, and not to apply a wrong form of therapy. Otherwise, we'll end up either losing the patient or doing more harm than good, and instead of healing, we'll be re-traumatizing. So I have done a video on this called re-traumatization. If you feel interested, do look at that video. How unknowingly somebody can get re-traumatized in therapy. That neither of us may know, but we may be doing more harm than good. And I'm also going to make up either write a blog or do a video on this called destructive affect mobilization. That when we try to mobilize affect to heal the patient, there may be certain situations where that mobilization may become destructive. And instead of helping the patient, make him feel worse and damage the positive relationship between the two. So I call it DAM, destructive affect mobilization, and I say damned if you damn. So this is one important aspect. Supervision and innovation are very necessary, right? And if it comes to fees, we have a sliding scale usually. We'll go into it later, where we can charge differently to different people based upon their income. One more important area is transfer. If you have to transfer the patient from one person to another. So there is a way of doing it. This happens to me many times, that somebody comes to me and after the case history, the person says, I cannot pay. So I cannot afford. I want to go to somebody else. So I then arrange for the other person. Or some person is moving out of the town and he does not want online therapy. He says, I only want in-person therapy. And he is moving to a different city. So then again the transfer comes up. Or it may be a transfer to B, that somebody was with a therapist, the therapist emigrated out of the country, the therapist does not do online, so this person is now searching for a new therapist and comes to B. Transfer issues. Termination will again come up later with that. When do you decide the healing has happened and termination happens? We'll come to it when we do technique. Now, where is psychoanalysis today and how is the journey? Okay. So psychoanalysis has two broad applications: clinical applications and non-clinical application. Clinical application is for psychotherapy, and non-clinical applications are for a variety of other areas. Once you say that psychoanalysis is a mother science of the human mind, then it can be taken to the whole of humanities and social sciences. So you can do psychoanalysis, you can do film analysis using psychoanalysis. You can analyze literature. You can take psychoanalysis to management. You can do interpretation of arts. You can take it to behavioral economics. You can take it to political science and sociology and many other areas. So you can divide the application of psychoanalysis into two. The clinical application, non-clinical application. You can see all the non-clinical applications in the slide. And the clinical application, of course, is for therapy. And we'll do some film analysis. We'll do some literature analysis. One of the things that I'll take up is one episode of Sherlock Holmes, Scandal in Bohemia, and we'll do analysis of it. And we can see how psychoanalysis can be used to analyze a Sherlock Holmes episode. And our work is also like that of Sherlock Holmes. From the data the person gives us, we have to find out what is in the unconscious mind. So it is a Sherlock Holmes work. Now, what is the criticism? The criticism of psychoanalysis are many. First, it is too long, amorphous, uncertain, and costly. So this is one of the criticisms, that we take too long, but then we go too deep also. It is amorphous. Some people have actually addressed this part and created a very directed form of psychoanalysis. For example, in classical psychoanalysis, when the person comes to the session, we allow the person to start the session. We never start the session on ourselves. So the person gives direction to the session. He starts where he wants to start. But some people give the direction here and say, last time you were talking about this, can we continue? Or would you like to address this part of it? In classical psychoanalysis, this is like a taboo, that you don't direct the session. But some people use a directed form of psychoanalysis. It is uncertain. It is not uncertain in that way. It's a criticism, but I don't think it is uncertain in the sense that we don't know whether we will benefit or not. Definitely will benefit. I have not seen anybody come to me and say that I spent so much money and time and got nothing out of it. So it is not uncertain in that sense, although people do criticize it that way. And it is costly, that I would agree, that it is costly. And if it is too costly, then we have to go for some innovation of group therapy. That can you do therapy in a group so that the cost is equally shared by everyone. So this is a specialty. Group therapy is a specialty few people do. They do therapy in groups. Problem there is of confidentiality. Okay? That people don't find it easy to open up in a group. Second criticism is, it is unequal and painful. It is definitely unequal. The therapist does not say anything about himself, but the patient, or in our language, the analysand. The analysand is expected to reveal everything. And when the person asks the therapist anything about his personal life, the classical answer is, this is your therapy, not mine. So the therapist is supposed to be anonymous as far as possible, a blank screen on which projections can happen.
But that is the case with any form of therapy, right?
Yeah, true. Except for in some forms of Jungian therapy and in some forms of existential psychotherapy. In these two forms, people do make self-revelations. So, Carl Jung, once a patient came to Carl Jung and Carl Jung said, "So you are in soup too," which was like admitting that I am also in the soup. Or in an existential situation, a therapist may say, "Oh, you are in this situation. What can man do in this situation? I was also in this situation 10 years back. This is what I could do and this is what I could not do. How do you feel about it?" So this would be a very philosophical existential exploration. But in classical psychoanalysis, we would try to be as anonymous as possible so that the transference is not contaminated and we get as pure a transference as possible. We'll come to what transference is later. It is painful. I mean, obviously, we are exploring the most painful parts of the personality, so it's going to be painful. And therefore, some people say it is masochistic, that people who love pain, they love psychoanalysis. It's not true. It's a criticism, but not really true. We proceed on the basis of short-term pain for long-term gain. That we take short-term pain because it resolves a long-term problem, not because we are masochistic and we love pain. It is abstruse and non-empirical. That is partly true because it's very difficult to do empirical analysis of psychoanalysis. Can anyone say why? Why do you feel it is non-empirical? Why can't we do a double-blind studies like we do in medicine?
Because everything that you address is very individualistic and
right.
Well, you can't have like a straight jacket rule for anything because it all depends on various conditions.
Right, very true. So each individual has a unique history, a unique constitution. And it's very difficult to have a control group where they share the same constitution and the same kind of life history. Second, we are dealing with extremely confidential information. So very few people would allow you to video record when you're talking about the Oedipus or rage towards the parents. So it's very difficult to get the material for really doing empirical research. In ISTDP, this has become slightly more easier, where we are more empirical now than before, but usually we were not empirical in that sense. Third, it is based upon materialism, except for you. It is true. That criticism is largely valid. It is savage, animalistic, focused upon pathology. Partly true. It is not as savage and animalistic as the critics point out. These words are too harsh. But is it focused too much on pathology and too little on our potential? The answer is yes. That we are focused more on the negative, less on the positive. This needs correction. It overgeneralizes and is based upon reductionism. That is true. How? Let us say you are a Freudian. So in your basket, if you look at what are the causes of any problem, you have the Oedipus, you have the three stages, the oral stage, the anal stage, and the phallic stage. We'll come to it. Okay. So in each stage, let us say there are 2-3 points. So we will have at least 7 to 8 different causes which will be the cause of all the problems. So all the sicknesses you have in DSM will have to collapse into those 8 or 10 causes only. So there is a reductionism, no doubt about it. But if we put the core concepts of all the schools together, we have a far more wider foundation on which to reduce all sicknesses, and that becomes more egalitarian, more pluralistic, and more correct also. I think we'll have to create a new session